surgery. So I'm honored to have a patient of mine. We're actually going to be proceeding with surgery tomorrow. And so this is one of those rare Facebook Lives that I've done where we're actually talking to the patient before the surgery. And so it's a pleasure to have you be here. You and I have talked multiple times. And it was, I remember your case vividly from the first one, from the first time that we had talked. And so having said this, let me go ahead and get started. Welcome to Michigan. Is this your first time
Thank you.
here?
It's my first time in Michigan.
Okay, now I will tell you this is the start of fall. It's officially on September 20th, but very nice, very good, weather here. It's not too hot, but it's starting to get cool, and we have one of the best foliage here, I would say, in the U.S. So, having said this, let me ask you this: when did you first get? You have two sets of implants. When was your first set?
The first set of implants I had put in was way back in 1984. And at that time, of course, they just did not tell you anything about any breast implant illness because it was like it was not a thing. They just put in these implants and basically said, okay, we're done, good luck, good life, goodbye. Like this is gonna last your whole lifetime. And that those particular implants I got were silicone, and they had this new and improved polyurethane sponge coating, which was supposedly to help keep the implant from developing capsular contracture. And so that after about 4 years, the right implant was really extremely encapsulated and painful. And I went back to the surgeon, and he was in Newport Beach at the time, and he did a manual capsulectomy.
No. So closed capsulotomy.
A closed capsulotomy.
Yeah.
So he basically, with brute force, just squeezed and compressed and tried to break up the scar tissue capsule.
Right. So the word closed means that that you are not opened up in the operating room.
Correct.
Capsulotomy means capsule, capsulotomy means you're trying to break the capsule. So very similar to you have an egg, if you will, and it's hard shell. And so you break it such that now after you have broken it into multiple places, the shell is not round anymore, and now you can press it, it's not hard, it doesn't impinge on the nerve, and now the patient is, relatively speaking, more comfortable. It doesn't necessarily correct the problem, but it addresses the problem of that firmness and hardness. And this can be done, and is usually done on a desk chair or a clinic office setting, or sometimes even the operating room where the patient's put to sleep, because it can be relatively painful. Imagine someone pressing, compressing, and kind of breaking this eggshell into small pieces, so now it's not as hard.
And that's exactly what they did. He did this like in the operating room with me laying on the same table that I had the implants done. However, the only thing that I felt any relief from was leaving the office, because nothing felt any softer, and I left with severe bruising for days after that. So that was really unpleasant. And ultimately what that led to was in 1994, then I had new implants put in.
1998.
In 1998, I'm sorry,
Yes.
Thank you, yes.
Yes.
That's what, then
14 years later.
14 years later. Long-suffering woman here.
Yes. So what led you to the second surgery?
The second surgery was, quite honestly, at that time, there was a class action lawsuit. A little bit earlier than that, so I believe it was around 1992.
That is correct. So 1992,
Mhm.
there was a ban on the silicone implants, and so there was a whole influx of people coming in, getting their implants removed, and they were getting saline implants because that was what was allowed. And so what's interesting is in 1998, you got what type of implants?
Silicone.
Silicone.
So just to clarify this, the class action lawsuit was obviously, to me, that was the first time I even heard or considered that there was something not exactly right about silicone implants. At that time then, I went ahead and I got money and I was just going to have them out, but I was newly married. And it's an interesting thing that I had not crossed my mind. My husband said he was concerned, he didn't care about the breast, he said. He was concerned, what would my psychological state be after having these out? And I hadn't thought about that. And then that put this little seed in my mind, like, oh, what how would I don't know. And so the next thing I did was re-implant. And yes, amazingly enough, it ends up, when I got my card afterward, it says Mentor Siltex, so they're textured silicone implants, and they're silicone implants in 98.
And what's interesting is you sent me the card, and at the bottom of the card, we will share that with our viewers. It says low gel bleed. So they're advertising, the manufacturers are advertising it's a low gel bleed. And remember, a phenomenon that we all agree, concur that exists, and it does occur. Now, so over the years, since you have this current set from 1998, so these are 27-year-old set of implants. Statistically, just the fact that you have these old implants, the older technology, you have a very high chance that you are ruptured on one or both. Just today, I did a Facebook Live, and this is a nice patient who had implants from 2007, and both of them were ruptured. So you can imagine this current case that I did today, she was just 18-year-old set of implants, and yours are 27. So now the longer one has them, the higher the chance for rupture. They're not lifetime devices, as we know through the FDA warnings and also the black box warnings. Statistically, you're supposed to get an MRI at every, initially after the 3 years, and then every 2 years they're onward to look for problems, rupture, problems meaning any fluid or serial ultrasounds, as you will see the recommendations made by not only the manufacturers but the FDA.
And excuse me, Mom, yes. And the black box warning didn't come out until when?
Just recently.
Just recently,
yeah,
right?
Yeah, so this was in the latter part of 17, 18, yeah.
And so the thing for myself and for all other women that are under this same situation, when you have the implants put in, and at that time there was no warning, they don't track you down and look for you to tell you, hey, you have serial number XX or whatever, and we need to let you know that this is the new black box warning, or these are the things you need to look for.
That's a very good point you mentioned, because I have had 2 patients within the last month and a half that I've operated on who got implants during this time in the late 90s and the 2000 to 2007, and they were part of an experimental study which officially the patient had to be enrolled in, but there was no disciplined follow-up. The patients were lost to follow-up. There was no check and balance. And the patients did sign that this was experimental reasons, but they never were followed up on a periodic basis, as was initially the consensus by the FDA and the manufacturers and the plastic surgeons, that they would do a routine, quick, yearly follow-up depending on what the plan was, so that they would monitor these newer set of implants. So there was none of this, and what is unfortunate is the patients are led to believe that these are lifetime devices, which is incorrect. They do rupture after the 10-year mark. The rate of rupture goes up. So you will see the many studies that are done, they stop at the 10-year mark because the rate of rupture goes up, and this is where the monitoring, the surveillance, or even removal just because you have met that mark It needs to be definitely followed up very closely by a board certified plastic surgeon. I have heard this from other patients who I have talked to that said that my surgeon found out that the implant is ruptured through an MRI or an ultrasound. And the surgeon then asked the patient, are you in any pain, discomfort? And the patient said no. And then her board certified plastic surgeon said, well, if it ain't truly broke, then don't fix it and leave the implant alone, which is wrong. It needs to be absolutely removed. And for someone to say that the implants are lifetime devices, it's a direct incorrect statement. The FDA and the manufacturers directly tell you that they are not lifetime devices, 10 to 15 years, sometimes sooner, sometimes later. Now tell us, so you got your implants in 1998. How soon thereafter did you develop a capsular contracture on the left side now?
So this is an important point, especially for women who think that it doesn't happen. Sometimes these capsules start forming as soon as the implant goes in, as soon as the body heals. So at the point of the switch out and the new implants, there was on this right side, which was severely encapsulated, there was silicone found all the way up under my clavicle. So then I got the replacement, and this was the Siltex, the textured. In 1 year, it was grade 4 capsular contracture.
On
like
the left side.
Hard as a rock on the left side. And I thought, this is a drag. 1 year later, and it's already like this. So, and then shortly after that was when symptoms started to happen, like a lot of symptoms. That it took time for me to start realizing what those symptoms were, because like a lot of women, you don't attribute it to the breast implants until you hear about breast implant illness.
What were those symptoms? What are those symptoms?
The first thing I had was a little bit of a heat intolerance, or excuse me, heat. I cannot handle heat. Humidity, terrible. I know sometimes women have the opposite, where they can't handle the cold. With me, it's like hot all the time, and I live in Las Vegas, Nevada. But anyway, so heat intolerance. And another thing I shortly noticed after that second set was, like, after a shower, I would get really these red blotches all over. It was weird. And then I had this like red butterfly across my bridge of my nose would get really red. And finally I went to my doctor for it, and I said, I'm seeing this, and I'm starting to like kind of lose it at work, like just feel really, really, really drained, and the heat, and he sent me to the rheumatologist because he thought I had lupus.
Lupus, right? Yeah, the classic butterfly rash.
Right. So that really scared me, and they did this. They did all this blood work, and it came back. They said that I had chronic fatigue syndrome, and my Epstein-Barr virus titers. I don't understand the titers and all that, but that it showed Epstein-Barr virus. And they explained to me that a lot of people have that. They ask you, have you ever had a really bad sore throat in your life? Well, yes.
We all have had it.
Hello, yeah. And they said in some people it just stays and manifests more. And mine flares up with the heat and humidity. So those three things then. I also had a customer earlier on that I remembered, and this customer, when I was a manicurist, she told me, she was a flight attendant, and it was the first time I ever heard of chronic fatigue syndrome, and the first time I ever heard of Epstein-Barr virus. And I said to her, well, it was shortly after I got my first implants. I said, what is it? And she explained it to me, And I recalled her. She said it's from breast implants.
Mhm.
So I thought that was really interesting that back then, some people were talking about it and some people knew, but it made me remember back to her, and that's when I really thought, maybe it is the implants.
There is no like direct cause relationship phenomenon that you will. Now, this is where, as you will see, there is no lab diagnosis. There is no imaging diagnosis. In your case, if you get an MRI, look today, the MRI said both the implants are intact, and it's read by the radiologist as a final report. And today I removed both of the implants, and both of them were ruptured on the first case that I did today. That was the 600cc ruptured implant. Now, the hallmark feature of breast implant illness are the rheumatological joint problems. What's interesting is both the patients today, one had scleroderma, the first one had rheumatoid arthritis. Now, if you look at the study out of MD Anderson, Dr. Clemens, there is a higher association between rheumatological problems like rheumatoid arthritis, scleroderma, connective tissue disorders, dryness of the eyes, and breast implants. But there is no one thing leads to the other direct causative organism, or basically etiology. So someone has implants and they're going to get Hashimoto's, or they got it because of implants. There are millions of patients out there who have implants, do not have rheumatoid arthritis, they do not have scleroderma or Hashimoto's. But there is absolutely what is mentioned clearly, autoimmune phenomenon, autoimmune issues that occur in patients who have implants. And in what capacity and how it affected you, we do not know. Now, only when the implant is removed and the capsule and all that inflamed tissue, and that you are free and minus, not only the implant and the capsule, but that spilled silicone on the right, and I'm going to assume spilled silicone on the left, then only then post-op we will see in what capacity and how you're going to hopefully bounce back to a better health minus these toxins.
Right.
Now, the next question for you is, how long, so you've known about breast implant illness for some time.
I have, and as my symptoms increased, like I always said, I have Dracula eyes, you know, they were always like, majorly bloodshot, and just then the physical things that accompany a hardening capsule, being the neck, the shoulder, the back. I have a laundry list of things. So then I started searching, and the first thing I did was contacted the surgeon that put them in '98 out at Cedars-Sinai Hospital, Beverly Hills. Went to him, even though it seemed kind of weird, because I thought, I'm gonna go to the same guy that put him in and talk to him. And he said he said I could take them out if you like, or he said what would probably be good is I could replace this one. Just this one.
Just not the right one?
No.
And when was this?
This was in it was 15 years ago. I can't do the math right now.
Okay, so 2015.
Right, so it was 15 years ago. So I went there and I thought, no, I don't want to put them in. I do want to get them out. And it was really interesting, Dr. Khan, because at one point I said, look, I want to show you how ridiculous this is and how I can only show you how it might hurt. And I laid down on the floor. And so this breast was the softer, it still is, behaved naturally. And this one just stood up like a little volcano. And he actually asked if I minded if he brought in a nurse, his assistant. And she was a young, really attractive, blonde, Southern California girl. And he brought her in and he said, look at this. And he said, you see that? You don't want implants.
Interesting.
It was amazing to me, but he was willing to redo it.
Yeah.
So from that time on, I left and I thought, I need to find somebody, somehow, some way to do this. Take this out. And I've looked on and off for 15 years.
Mhm.
I've seen surgeons, I watched hundreds of YouTube videos, and I listen to what their dialogue is even during, during their surgeries. And you have to do your own homework, right? You have to see, like, how do I feel about this person? Not just their technique, but the more I watched, the more I learned, and the more I knew to look for. And I got some help from some social media groups, but you get to a point where you have to figure it out for yourself. And amazingly, um, about 6.5 weeks ago, I got into another group and I had just seen your name for the first time.
Mhm.
And I saw that somebody said explant only. It was like, what is that? Is that literal? Explant only? And I researched, and within like a week of watching videos, it's like, I think this is my guy.
Mhm.
I don't like that I have to go to Michigan, but I think this is my guy. That was the truth. And I checked a few other people, one right there in Las Vegas,
Mhm.
and one in Southern California. But the way they did their surgery, their technique, their ethic, it's just like, I know they could do it and I probably have an okay result. But I have not seen anybody say and do the things that you do. But to this day, I'm not saying there isn't somebody out there who doesn't say things like 100% of the capsule, 100% of the time with zero capsule left. That's like mind-boggling to me. And I would like it if any of you out there know somebody like that, because I think we need to know more people like that. And so that just was it. I got to that point where I thought, you know what, I don't want to do this in a Mickey Mouse way. I don't want to just have not 100% of the job done. I don't want to have to do it again. I just want it done once and for all. And
No, this is very well said. I will tell you, a lot of plastic surgeons in the United States, well over half, I would say, are doing explants now. Everyone has their own formula. Yesterday, we had the patient from France who said that their plastic surgeon said that you don't have to remove the whole capsule. The capsule is inert. It basically will dissolve. This whole surgery is about the capsule. So the classic example is the patient done today. Had she not had a total capsulectomy, that fluid, that mud type soft tissue brown mass would have spilled into the chest. The spilled ruptured implant silicone would have spilled into the chest. The capsular tissue would have been left behind, into which it is seated, that ruptured silicone. All of the badness, the implant, capsule, all inflamed tissue was removed. And this gives that patient and the next patient who's watching that peace of mind that it was done completely. God forbid she has what is CD30 positive. We're not coming back to redo the operation because it was already done to begin with correctly the first time. And the only and the ultimate way that you can authenticate and be at peace of mind is where the surgeon is very transparent and showing the high definition videos and pictures of the chest wall, showing complete removal of the capsule and implant and all inflamed tissue, and only good, healthy, viable tissue remaining behind. Because that is the ultimate visual proof with the high definition pictures, giving it to the patient afterwards, saying this is how the surgery was done, this is the cut, this is how far I went up, this is how, especially in your case on the right side, and very possibly on the left side, that ruptured free-flowing silicone needs to be removed as much as the capsule. Your surgeon attempted to remove the capsule because of the capsular contracture on the right side, and maybe that spilled silicone made it past, and if it's bathing, sating, and those fatty tissue around, I need to remove that because it is going to have developed a silicone granuloma, irregularity, masses, whatever it may be. Going into your surgery tomorrow, a very high chance that not only the left with the grade 4 capsular contracture is ruptured, but also the right, even though it is relatively softer and benign appearing. Your implants are 27 years old, and the very high, and they're older technology, And these are not the nicer newer gummy bear because they still ruptured. The newer ones from 2007, when they were reintroduced to the market, they indeed ruptured, as you saw, despite what the MRI said. And the bottom line is, it's a relatively involved process. Remember, we even talked about maybe your first surgeon put it above, which we know he did, and the second one put below the muscle. So I have to check and make sure there is no residual capsule from the first surgery, and if the second surgery was done below or vice versa, right? Because I don't have an operative report from your first or second surgeon. Now, let me ask you this, how did you prepare for the surgery?
Um,
Like, what did you do? Like, what type of networking research?
Basically, after I had already found you, I think I filled out I went to the website and the contact form. First I prayed, I'm a prayer. First I prayed and then it was like within a day, I thought, I need to just do this. I really feel this guy is my guy. And I emailed the office and that set the ball rolling. And that was like the end of July. And I was trying to get in for August because I just thought, no, this is the guy. After that, it was just getting ready for, doing whatever tests I needed to have done. And my insurance had just changed, so I didn't even have, I had a PCP, a primary care provider, assigned to me, but I barely go to the doctor, like, ever. And so I had to do a lot of things really quickly, and it wasn't easy, it was really stressful for me, but I really wanted this, and I just kept praying and hoping that it all came through, and it did. I mean, we were like on the last day, I was still getting a test on the last day that I was supposed to turn in my paperwork, and so.
Now, this is very important. Every patient that comes to me, 80%, 90% of the patients that come to me, they travel, they're out of towners. And so as they come to me, I want to know everything about them. I want to get the medical clearance. I want to make sure that the thyroid levels, the iron levels are good, the rest of the numbers are good, that there is no underlying problems that were potentially missed. And yeah, there are findings that are made that need workup. Sometimes the nurse practitioner might feel uncomfortable, and you have to get that peace of mind so that when you have the pre-op clearance, as you come to me, I know that there's going to be no turbulence tomorrow, and it's going to be very nice and smooth, that you don't have any good bleeding tendencies, that you don't have any underlying heart problems, lung issues, and that overall you're not a diabetic. There, believe it or not, millions of patients out there who are diabetics and they don't even know that they're diabetics. So we want to make sure that they are optimized, ready, and that they're all healthy for the surgery. And this is the check and balance that I myself go through, as you saw firsthand, so that when you do come to me, you're vetted not only and cleared by me, but my anesthesia team independent of me. And so that we have done our due diligence so that we know exactly who you are. And as you come, we already have reviewed your chart and reviewed it thoroughly. Now, let me ask you a question. As you go into the surgery tomorrow, and this is kind of a tricky question, but I think a straightforward question. What are you expecting post-op? Because this is one of those rare questions I've not asked anyone, because we're going into the surgery tomorrow. What do you expect? What do you anticipate? How are you going to feel afterwards?
It's a great question. I'm really glad because it's something I've been thinking about a lot. And I brought one of my excellent friend, godmother, with me, and I have two godmothers that I think. She's with me. We've talked about this a lot. First off, the only thing at this point in my life, the only thing I'm really looking for right now is, first off, I would hope that just the pain of this is going to be gone, simply by removing it and some healing, because I don't expect magic, miracles. It could happen though. I mean, if that pain and released all this tightness in the neck and the back and the shoulder and even the pins and needles, that I feel, that would be amazing. If I slept better, that would be amazing. If symptoms started to clear, that would be
What
amazing.
symptoms are you specifically talking about?
The biggest one for me is in the summer, my heat intolerance is so bad. Basically for 6 months, I'm just indoors for 6 months of the year. I can work from home, but the fatigue, there are, and this year has been a little better. I'm not sure why, but the fatigue has been so bad at points where there were days that I'd get up. If I could make myself some coffee, that was the main goal, was to make myself some coffee. If I could brush my teeth, grab my coffee, and then go lay down again. And that's just no way to live. But I'm hoping many other, if that heat intolerance can back off, that would be amazing. If it doesn't, it doesn't. But I don't really have these expectations. I have hopes, and I have all my, all my aches and pains and all my different things that I believe are probably breast implant illness related. So the way I look at it is reverse engineering. Like, here's all the stuff. I didn't do all the tests beforehand to find out what I'm positive for or negative for, apart from the rheumatologist, and that was quite a few years back. So, Lord willing, with the healing, doing the healing just like under your orders, like just what I'm supposed to do, then I can hopefully start checking things off the list in time.
Sure. Now, I just want to mention a few things, and these are hard facts. Just the fact that your implant is from 1998 in itself alone is a reason to go for surgery tomorrow, case closed. And you might as well just get up and say, even if you have 0 symptoms. Because remember, we already said that you have a very high chance for rupture on the right and also on the left.
Yes.
Just the fact that you have pain on the left side, grade 4, Baker's classification, capsular contracture, ever since 1999. And for 26 years, you have lived in pain on the left side, and you have a contracture, hard like a rock. If you start moving your arms around, you're going to be limited, restricted, because there is this hard piece of ball, solid, that's sitting on your chest. Literally, if you tap on it, you're going to hear it, and we have seen this many times. No one should live like that, period. Even if it was not painful and a hard ball that you had on the right side the 4 years after your 1984 surgery, no one should live with a hard ball on their chest. Fact that you have what is, remember, the most common symptom that the patients present with is the fatigue. If you have 1,000 patients and you see that they have improved, the fatigue is the most common complaint that these patients have. And obviously you have had the chronic fatigue syndrome. Now we know your thyroid is good, your iron level is good. Now someone will object and say, well, you're postmenopause, you're 68.
I'm 68.
Yes, and I will tell you, 68 is not old, but not young either, right?
It's older.
Older, right? And the point I'm trying to make here is that, there are people that I know at 68, surgeons who are literally operating every day and working hard 60, 80 hours a week, and they have a full career. I know someone 78 operating every single day. And the point I'm trying, and many CEOs of the hospital, that CEOs of big companies at 68, they're like, they just became this, or they have the experience, or, now people start, nowadays, now depending on the genes, depending on who you are, now each one of those symptoms that you mentioned, the visit to the rheumatologist, the findings that were inconclusive, these are what are suggestions of what is breast implant illness, till proven otherwise. Now, for those reasons alone, that each one of those check boxes, we will see and we'll hear from you directly post-op, be it later on in the week, next month, next week or whenever you're ready, we will hear and see in what capacity and how the before and after. The implants ultimately only, if you will, harm. No one walks into my clinic and says my brain is thinking sharper, I have more energy, I can run faster, I can throw the ball higher and more. I have basically better breathing, better GI, it's only a problem. Sooner or later, and as mentioned by the black box FDA warning, breast implants are not lifetime devices. The longer people have them, the higher the chances are they're gonna have complications, some of which will require more surgery. And so you will see that after some time, one might say it's your 68 years of age. Sometimes it might say it's the postmenopausal effect. Sometimes it's just the bad, whatever it may be, that your body might be going through a phase in life, maybe by the cold weather, and now, it might be. The bottom line is post-op, we will know. And in my practice, 90% of the patients and more improve, benefit from the explant surgery to the point where two things are almost always said by my patients. Number one, they wish they had never gotten implants. They wish they had removed them sooner so that they could have reclaimed their life better. Tomorrow, I use the word with absolute 99.999, if not 100% reassurance, no hard tissue will be left behind on the left side. All capsular contracture, irregular, abnormal, potential inflamed tissue, fat necrosis, whatever it may be, because of the inflammation, anything abnormal will be removed in a very tedious, meticulous, detailed fashion. Anything good, healthy, viable will be left behind. So I can reassure you that your left side will not be hard. I will reassure you that I will look on the right side and also on the left for any spilled silicone. Anything irregular, abnormal, if I'm even sitting on the fence, I will remove it. Because it has to go to pathology. My eyes cannot tell if it's, God forbid, that very rare lymphoma or not. If there's fluid on the left side or the right, it will be sent to cytology. Cultures will be done for bacteria and fungus. You will get the implants back, hopefully both intact. I took care of a patient not too long ago. She had implants from 1979 and both of them were intact, to my surprise. And I mentioned this on the Facebook Live, and good for the patient. Now, this is where that patient needed to remove them regardless that they were ruptured or not, because it had been in there for over 4 decades. The second patient today that I did, she actually was walking, smiling, and she was singing a song towards the operating room. And this is how excited she was that she's looking forward to her surgery. And this is how the patients come, because they have done their homework and they feel that contentment in their heart that their good health awaits them. And so this is what I anticipate, and hopefully we'll have a lot of answers tomorrow.
Yes.
Thanks, Fourth, for coming forward and discussing your journey and for sharing your experience. Because like you, I will say there are millions who have contracture, irregularity, abnormality, pain, malposition, and they have had implants over 10, 12, 15 years. They have never had any screening for potential rupture, and unfortunately they're scared to get mammograms even because they feel that that might have the pain, right? And there are a lot of patients who we need to educate so that they learn that these implants are not lifetime devices. The very rare association with lymphoma, not only lymphoma, but the other like squamous cell cancers that the FDA has highlighted, and that not everyone gets breast implant unless symptoms, but the small subset that do, that there is a solution to it, which is removal of the implant and the capsular tissue, and doing it right, doing it once, and doing it with definitive certainty, completely, comprehensively, such that when we look back at it, we know we got everything out and we got everything tested. Now, anything else you want to say before we conclude?
Actually, I'm really excited. I just saw your, yesterday I saw that you'll be coming to California on September 20th
Yes.
And I contacted the office right away and said, if I will fly to California if you want to do a follow-up, so I could have an in-person
Absolutely.
follow-up. So I'm really excited about that. So that's looking ahead still, but, ladies, you educate yourselves. Educate yourselves, watch videos, learn from others, and don't just, you're smart and you have to figure out what's gonna work for you. Um, just educate yourselves. Watch videos and learn from the surgeons themselves. See what it is, what appeals to you. For me, it's, I wanna be done with this nonsense. I just wanna be over and done with it. And so I'm really blessed to be here. I thank God for that because it did happen in a short period of time with a lot of hard work and prayer. And I thank you. It's really interesting talking to you before. I know you're going to be opening me up and taking all of everything bad out that you see. And I'm not even concerned about what I'm going to look like. I mean, would I love to come out looking like my 27-year-old perky self? Yeah, but that's not going to happen. So, it's just realistic.
I wish I looked like a 27-year-old myself, but I will
Yeah.
say this to you. I have had many patients I've operated on, the 70-year-old, the 78-year-old, the 89-year-old. I'm going to go ahead and place a dot at the nipple on the right and also on the left. Now, the left side is very much contracted, hard shell, and you can see the right side is more basically spread out. So I'm going to go ahead and remove more of the skin on the right, and I'm going to measure the distance from the nipple all the way down to the crease on the right so that it's going to be symmetric to the left, because this is my chance. And then I'm going to go ahead and remove some of the excess skin from the bottom, which is the pseudo lift. And I'm going to talk about this in my next talk and at great length, where I remove what is that excess skin where the implant, once it's bottoming downward and outward, where the implant has worked as a tissue expander. I remove that excess and then I put internal sutures that help lift the breast tissue upward and medially. Between the fluffing effect, as the implant is not there, and the breast tissue now gets a chance to fluff out, because the pure proximity of the implant to the breast tissue causes the breast tissue to diminish and atrophy. With that being gone, with the excess skin removed, and then internal sutures that I put that helps physically lift the tissue up, with the implant gone that literally gravitates and pulls the breast tissue down, and with the implant gone, now the breast tissue recoils and the skin recoils. Now, someone 68, you will see that the amount of breast tissue that you have is certainly a whole lot less because of the postmenopausal effect, less estrogen, progesterone, and the breast tissue starts to atrophy just the 68 years of age alone, and it gets replaced with fatty tissue. Now, I am not going to touch the nipple areola complex or the breast tissue. I'm going to be strictly what is above the muscle, and I am going to be below the breast tissue in that compartment, if you will. I'm going to visualize and see if the muscle was cut maybe by your first or second surgeon. This is me being thorough and complete because I don't have the operative record from your first or second surgeon. I do not know if they're even above or below. Now, you are saying that they're above. Now, if the muscle is intact and pristine and there is no cut, then we know both of the implants were indeed what is above the muscle. Between the fluffing effect and between the 5, 10, 15, 20% muscle mass you're going to add to your chest as you work out, because all these years you have been contracted, you have not moved your arms and shoulders, you're going to find that aesthetically you're going to look hopefully very reasonable compared to what a 60-year-old person would look like. If I talk to the next 168-year-old patients, they not only, and they have had no implants, they will not only need a breast lift, but a face lift, a thigh lift, and an arm lift. The point being, everything sags because the fatty tissue gets less and the skin elasticity gets less. The fatty tissue on the face starts to diminish, and now everything tends to kind of fall down. By taking care of yourself, eating healthy, being well hydrated, not smoking, avoiding the sun, avoiding alcohol, things like that, that really helps nourish the body. Having a good night's rest, for example, and keeping the cortisol level down. In addition to what is natural, organic, like olive oil, coconut oil, and having a nice, peaceful demeanor, I believe it or not, that goes a long way as far as aging. One of my mentors did a study on twins. They are identical twins. One of them was sailing and smoking and drinking. Another one was in the computer room for most, and you could see the aging from the sun and you can see what, you know, environmental effects does to the face and body. You will see, and I'll end with this, if you just, so one of my anesthesiologist friends, another plastic surgery colleague, another internal medicine doc, emergency room doc, and these are all my friends that I've worked with, associate with, they question as to what I do, why I do in the manner and what I do. And they said if there is even validity to any of this. I said, well, why don't you go to Google and type in explant before and after face, and you will see that many patients from their 20s to their 70s, 80s, you will see their before and after faces, and you will see they all got technically a facelift. The inflammation on their face is gone, they look healthier, the edema around the eyes, the swelling, the rash type feel, that, all of that, and you will see that right before your eyes. And the many patients who come forth and discuss and share their journey, the resolution of their many symptoms, the dryness of the eyes, the redness of the eyes, their rashes on their face have all improved for the better, and you will see, and these nice patients have nothing to gain except for spreading the good word that the implants are indeed causing them harm. I had a patient came to me, she wanted a blepharoplasty, and I said, you don't need a blepharoplasty, you need an explant to get that edema inflammation off of your face. And lo and behold, she ended up getting it, and her face only improved, as you have seen the many, I would say thousands of patients who have come forth and shared their journey.
Amazing. And just to make sure, if we do an after, I'm gonna wear the same thing, which is just lipstick, just mascara, and a little touch of under eye cover. That's it. Because if you're gonna do a before and after, it has to be in the same lighting, with the same clothes, and the same whatever. This has been awesome. Thank you.
Likewise.
I'm really happy.
Yes, likewise. It was a pleasure to talk to you. Thank you very much for coming forth and sharing your journey. And, I want to go ahead and, I like how you have taken this leadership role, where you just told me for the first time I heard that you have bought this domain name. Please tell us about that.
I did, and I designed websites, I'm a webmaster, and it took it so to heart that I want to see explant surgeons who really, they don't do implants. They just don't do implants. They really believe in breast implant illness. So I bought this domain name, which I'll reveal later, because I want to get started on the website during my recovery period. I can do that. And I'm really excited. Again, as I said, if you know of surgeons who truly do en bloc, explant only, they're not associated at all with doing implants, that's gonna contact me through Facebook, through Dr. Khan's website or Facebook page, because I want to feature those people. I think it's a really special thing, and it's a really important thing. How else to say you really believe in it and you're certain that it causes the problem it does. Mentor wouldn't put, that they now put on their box, on their black box warning, all these issues, but they do, because it's real. So I want to really go ahead with that. Over the next few weeks, I'll be working on it. I already have a Facebook page set up for it. So I'm just gonna go forward and hope to interact with a lot of people and help more people, just help more people, for nothing even, for not for, any financial gain or anything, just to spread the word.
No, I will tell you, you are a honorable lady and a lady of faith. You mentioned earlier, and you have only one wish and no disclosure. There is no financial incentive. And I will tell you, this is a website for the patients, by the patients,
Yeah.
and by a team, so that you can, and I want you to do this, because this way, there is no bias other than to help the next patient understand with full what's transparency, how the surgeon does it, if there's any previous videos of the chest wall, if the surgeon or the business of that surgeon as a whole under that roof is entirely committed to, if there's 5 surgeons, all 5 of them should be explanting, not one is dedicated to explanting and the other one. And this is for the patients, so that there's no confusion and there's complete, confidence and peace, so that as the patients make their decisions, there is no bias that's fed into them, there is no one who's coercing them, and it comes willingly, so that they themselves are talking to the surgeons directly, not to their liaisons or to their medical assistants or to their nurse practitioners, physician assistants, office managers, or basically, what they call, the liaisons, none of them. So you're talking directly to the surgeon, because that's the bond that you have with me.
Yes.
And to no one else. And this is what you have entrusted me with, so that the next patient can learn and educate. And the best person is you mentioned earlier, very importantly, talk to the surgeon's previous patients, because that's where the wealth of the knowledge is.
Yes, thank you so much.
You're welcome.
Thank you so much. I see a bunch of you have asked questions, and
I'll
do when I watch this, I'll answer any questions that I can.
Okay. I'm gonna go ahead.
Thank you.